Neil, so thank you very much for the pleasure of participating in the CME program. I must say it's truly remarkable what you all have accomplished in only 10 years as an organization. And I've really enjoyed my friendship and also working with you on many programs in collaboration with Med Reviews and LUGPA. So focal therapy, ready or not? So I'd like to first begin by looking at the diversity of localized prostate cancer. So I've seen patients from the age of 37 up until 83 with a diagnosis. The diversity of the disease, a millimeter of Gleason grade group 1 versus multiple cores for Gleason grade group 5 with extracapsular extension. And there's a diversity of the treatment priorities. Just cure me, doc, or I'd rather die continent and potent rather than live with incontinence and no erection. So I believe the optimal management of localized prostate cancer in 2018 with that the diversity of disease of the patient and the priority is a radical prostatectomy, radiation therapy, active surveillance, and I do put in focal ablation. So what is focal ablation of prostate cancer? It's the utilization of physical energy to destroy prostate cancer. So the ablative energy may be delivered by focusing the external energy source into the prostate, such as with HIFU, or inserting an energy delivery system directly into the prostate cryo. It's an outpatient procedure performed with or without a general anesthesia and fewer complications than standard whole gland therapy. We have several energy sources that are commercially available in the U.S. today and others under development. So the extent of focal ablation remains controversial. One can simply destroy the lesion. Based on the work from Samir at our institution, we realize the MRI lesion underestimates the disease, so we'll add a margin. It can be quadrant, hemiablation, or hockey stick. And of course, what are the potential advantages of focal ablation? It's targeted. You can repeat it. It's an outpatient procedure. It's lower cost, fewer complications, and who knows, maybe an induction of an anti-tumor immune response. So what are the treatment goals for low intermediate risk prostate cancer? It's to return quickly to daily activities, no protective pads for incontinence at any point in time, preservation of sexual function, avoid short and long-term treatment complications, and obviously prevent the mortality and metastases from the disease. So this is the case for focal ablation, what you must believe, and I hope David's paying attention. So first of all, many will dismiss focal therapy because prostate cancer is, we all know, multifocal. And in fact, recently when we looked at a group of 200 men undergoing radical prostatectomy, almost 90% were multifocal. Nothing new here. However, with imaging and our targeted biopsy program, we're able to identify 90% of what we term the index tumor. Again, this is from the PROMIS trial in the UK, and this was not centers of MRI excellence. This was with 1.5 Tesla magnets, and this isn't simply looking at your ability to identify biopsy disease, but they did template biopsies. So this is actually the ability to identify any disease. And the negative predictive value of MRI for significant disease was 90%. So the MRI can identify it, but can we actually detect it? And this comes from the Precision trial. And our goal with biopsying is to identify significant disease and not identify low-risk disease, because the best treatment for low-risk disease is not active surveillance, it's not detecting it. And that's exactly what MRI-targeted biopsies will achieve. In addition, Gleason grade group 1 is not lethal. We know that if we do focal therapy, we're going to leave Gleason grade group 1 disease. And so focal ablation will leave this behind. Is this a problem? No. We looked at about 1,000 men who were actually Gleason grade group 1 based upon the prostatectomy specimens. And at 10 years, not a single patient developed metastases. And what is the preferred treatment for Gleason grade group 1 disease? Certainly in these cases, it would be active surveillance. Now, David raises a concern that we're going to leave significant disease behind with focal ablation. And this is a study we published about 5 years ago. And again, we're looking at the different proportion of Gleason pattern 4 in radical prostatectomy specimens. And the top plot is actually looking at low volume Gleason pattern 4. And if you follow this out to well beyond 10 years, 80% of men have no disease recurrence, and the majority of those that recur is actually local recurrence. So who are candidates for this just be focal ablation? It requires a pre-treatment, high-quality, multiparametric MRI with a unilateral MRI lesion, Gleason grade 6, Gleason grade group 4, less than 4, concordant with the MRI lesion, no Gleason pattern 4 in the contralateral systematic biopsy, no gross extracapsular extension, and no apical MRI lesion extending to the distal prostate. This would be extraordinarily difficult to ablate. Now, this is what I feel is the most important slide justifying focal ablation. So what we did is we looked at 59 candidates for focal ablation who underwent radical prostatectomy at NYU. So we're not looking at the ability of our diagnostic paradigm to correlate with any radical prostatectomy. We're saying these are the candidates for focal ablation who fit our criteria. All of these men underwent an MRI at our institution and our fusion target biopsy and systematic biopsy. And what we did in the radical prostatectomy specimens, we examined for the presence of Gleason pattern 4 outside of a focal ablation template. And that template would have been lesion plus 10 millimeters when feasible, or a hemiablation. And again, no surprise, 92% of the time, we were able to identify the index lesion. And again, in this cohort, we had a higher proportion of men with unifocal disease, because again, we're not looking at the whole spectrum of men who are undergoing radical prostatectomy. This is the relevant group of men who would be candidates for focal ablation. And what we found is that if you did a hemiablation, then about 20% of men, you will leave some Gleason pattern 4. But in virtually all cases, that was less than a millimeter. And if you did with a lesion, it was just a few percentage points higher. So I would imagine if I asked David or others, how would you manage Gleason grade group 1 today? It would be absolutely active surveillance. But we know when we take out those prostates, 50% of men have Gleason pattern 4. So the patient that I'm selecting for focal therapy actually has lower risk disease that would be left after an ablation than someone we all put on active surveillance. So if you can follow men with 50% chance of having Gleason pattern 4, I would say it's perfectly reasonable to follow 18% and much lower volume pattern 4. Can we reliably destroy clinically significant cancers? Again, if you look at there's a range within the literature, but this is based upon biopsying the ablation zone 6 months to 1 year after the targeted therapy. It ranges between about 10 to 30%. So we're getting pretty good at ablating the lesion. But again, one of the concerns I have with HIFU is having confluence of the energy. And I think that's where 80% is not bad. This is biopsy negative. But I think we still have room to improve our energy systems. And of course, quality of life is important to men. I'm going to rely on expert opinion. I think we'd all agree that this is highly relevant. So in selecting candidates for focal ablation, there's excellent, there's good, and there's marginal candidates for any intervention. I think some of the factors that are going to influence your treatment decision is life expectancy. the site, extent, and aggressiveness of the disease, the outcome priorities of the patient. You know, a radical prostatectomy can be a very reasonable option, but if someone's going to be devastated by potential complications of sexual dysfunction, then it may not be such an excellent option. So men must be involved. This must be a shared decision process. And in counseling patients, it's so critical to give valid outcome expectations. So the extent of the ablation really depends upon the risk of the disease and the location of the disease. The extent of the ablation, I think, may impact the complications of a potential of a future salvage radical prostatectomy. And I do believe that using a fusion platform may actually facilitate the treatment planning. Most patients will come to me and they'll say, "Doc, if I do the focal ablation, if I recur, can I go on to a radical prostatectomy?" I believe the answer is yes. It's a bit more technically difficult. However, almost every patient so far that has developed disease in the ablation zone simply wants another ablation. So the treatment-related risks of focal ablation, initially there's an increase in their LUTs, but actually if we look 6 months later, there's improvement. Post-procedural retention just depends how long you want to leave the catheter in. If you leave the catheter in for 2 days, some will come back in retention. You leave it in 5 days, that's highly unlikely. Tissue sloughing, especially when you don't preserve the urethra. We have yet, in about 200-300 cases of focal ablation at our center, yet to see any patient experience any level of incontinence, even immediately after catheter removal. I do believe that there is an adverse effect on sexual function, erectile function, the greater the extent of the ablation. Certainly when you see the lesion encroaching upon the capsule, we extend that ablation zone, and I think those patients have more likely to have a transient impact on erectile function. And again, counsel these patients because they're so focused, many of them, on preserving erections about seminal volume decrease. You know, they'll come in, and in fact, we had a patient, their PSA, it's not uncommon when we even do the focal, the lesion with a margin. We had just a patient that came in, his PSA was 10, post-treatment it was 0.6. He went back to work about 4 days after his procedure, actually had an improvement in his symptoms, erections were preserved, but he was really actually concerned that his seminal volume was a bit diminished, and it was hard to commiserate with the patient with that outcome, but I think it's important to be fully forthcoming. So how about post-ablation management? We'll usually take the catheter out 2 to 4 days, depending on the extent of ablation. We'll look at any complication 2 weeks later. We'll get PSAs in 3 months, and then every 6 months this after. So at the moment, our protocol is every patient at 6 months get an MRI and a targeted biopsy of the ablation zone. We put 4 targets into the ablation zone. We're reassessing this because, again, in our experience, if in 6 months you have a negative MRI and you have a stable lowering of the PSA, the likelihood of finding significant disease in the ablation zone is very low. And if this continues to be the trend, we'll actually simply advocate an MRI and a PSA without a biopsy. We're now getting into 24 months, so we're doing biopsies at 24 months. And if we see a progressive rise in the PSA at that 12-month period, we'll do a for-cause MRI and biopsy. Well, how about oncologic control? What should be the definition? Well, oncologic control must be defined by biopsy until we have evidence showing that the MRI and PSA rules out significant disease. Now, if we put 4 targets into the biopsy, we come up with a millimeter of Gleason 6, a Gleason grade group 1. That's not an oncologic failure because that wouldn't be an indication for intervention in my assessment. A small focus of pattern 4 in the ablation zone should be considered failure to achieve oncologic control. But based on age, PSA, and MRI findings, it actually may not trigger retreatment, but should be reported as oncologic failure. So optimizing outcomes, training, patient selection, meticulous technique, and rigorous oncological assessment. So what do we know about focal ablation of prostate cancer in 2018? We know it's an outpatient procedure, very minimal treatment-related complications. It is a very expedited recovery. Again, with a fairly large experience, we'll say no incontinence, modest early erectile dysfunction depending upon the extent of the ablation, and that we can reliably destroy the target harboring disease, certainly based upon our 6-month data. So I participated in the last man standing debate at the AUA in May. We almost made it. We came in third. It was sort of going back and forth in the voting between active surveillance, and I was given hemiablation with HIFU. But this is a gentleman, 67-year-old, had a 36-gram prostate, a shim at 22. He had a single MRI lesion. He had 2 cores positive, Gleason grade group 2, limited to the MRI lesion. He had a focal ablation in May. This is when he left the operating room at his 10:38. I have no way of proving to you this is the same day, but it is. And by the clock at 1 o'clock, there he was walking out, almost as if he didn't have a procedure. So this is really a minimally invasive intervention. What don't we know? We know there's a lot we don't know that's critically important to know. We don't know the optimal energy source. We really don't know the extent of ablation. We really don't know what is the optimal post-ablation assessment of oncologic control, because that's critical to know. Is it just PSA? Do we add an MRI, and at what point? And when is it necessary to do a biopsy? We have no intermediate or long-term oncologic outcomes, and I would say at least the early the real question is, and what patients ask me, is there oncologic compromise? And my sense is that as long as the patient returns and realizes they're still in an active surveillance program, which just like with active surveillance for low-risk disease, that it is going to require PSA, it's going to require imaging and indeterminate and likely repeat biopsy, no different than active surveillance. I believe that we won't miss a window of opportunity to cure that disease if they had curable disease at presentation. But that's where I say I'm hopeful. Selecting the energy source, the size of the prostate, the location of the cancer, the startup cost, the precision of energy delivery, and the out-of-pocket costs. So again, I'm confident the lesion will be successfully ablated. I'm confident there are few Gleason grade group 1 cancers untreated, in fact, fewer than the patients I put on active surveillance on the basis of a systematic biopsy. I'm very confident there's no impact on continence and minimal impact on potency. I'm uncertain, of course, whether clinically significant recurrences or new tumors will develop during the patient's life expectancy. I'm confident we don't burn bridges for future curative intervention. And I must say, I'm hopeful that there's minimal, if any, compromise of oncologic control as long as these men are adherent to our surveillance protocol. The preliminary results are encouraging. The intermediate and long-term outcomes are lacking. Urologists must play a responsible and leading role in assessing indications and outcomes. Patients must be informed of both potential benefits and harms, realizing that long-term outcomes have yet to be defined. Industry must commit to training. This is not so simple. If done responsibly, focal targeted ablation has the potential to advance the treatment of prostate cancer. If done irresponsibly, patients are going to be harmed. So is it ready for prime time? Focal ablation must be one of the many tools available to the urologist in order to optimally treat the spectrum of prostate cancers and the varying priorities of men with this disease. Focal targeted therapy, I believe, is ready for critical investigation. Not so sure that means prime time. Those urologists who offer focal therapy must disclose the limitations of treatment, optimize surgical technique, My big concern is when you do a radical prostatectomy, you have a PSA that's measurable, you know you did a bad radical. Or if they're incontinent, you know you did a bad radical. You don't know if you did poor ablation. The patient's happy as can be. And there needs to be thoughtful patient selection and meticulous follow-up. So in terms of, I know there's a lot of ways that one may be dismissive of focal therapy. I do believe with our imaging capability and our biopsy capability, we can identify a group of men where I think this is a very reasonable option. But in fact, if you offer this, there must be a commitment on your part and the patient's part for careful follow-up. Thank you very much.
Dr. Lepor, thank you very much. That was a great presentation. There's obviously the elephant in the room is always going to be the question of multifocality and the possibility of about a 10% false negative rate on MRI. Dr. Crawford mentioned things about templating and doing that as a precursor to something like focal therapy. Could you comment on that?
Look, I think if the morbidity of a saturation biopsy was that straightforward, and you're going to do this on all patients, right? You know, there's a significant risk of retention. It requires a general anesthesia. It is very different than performing a targeted biopsy with or without the systematic biopsies. So in the real world, if this was an equal procedure, of course I would recommend a templated a saturation biopsy. The problem is these guys have already had a biopsy. I don't think any of us would recommend that their initial biopsy for every patient should be a saturation biopsy. So then do you take these patients and subject them to another biopsy with that morbidity? I think the data we showed is very compelling. We're not talking about all patients for radical prostatectomy. We're talking about those patients who you have selected for focal therapy. And I will tell you that the likelihood we will leave untreated Gleason pattern 4 is far less than what you'll follow in your active surveillance protocol. So we may not be perfect, but I do believe the paradigm that we propose is leaving very low volume Gleason pattern 4, and I think that's safe to do.
So Herb, great talk. Can you comment maybe a little bit about, the prostate, as everyone in this room knows, is just a remarkable organ in that our ability to access it in the clinic. So what about, the history of direct injections into the prostate? Whether it's, moving away from ablative technologies, although there's a steam technology that may be looking at focal therapy, but other injectable technologies, which are really ultimately probably best assessed as truly being minimally invasive.
Yes, so I think, Neil, you're always one step ahead of everyone else in your thinking. So the question is, really confluence of your energy or whatever energy you're going to inject. My concern with an injectable is how it diffuses and whether you're going to end up truly within what is your planned treatment zone going to have concordance. But something like the steam, it may be very, very interesting, but again, does that require an anesthetic? I think once you're with an anesthesia, a general anesthesia, which we really recommend, I just think all this is conceptually reasonable. I think the limitation that we have is confluence of your energy, and if we could show that we can deliver this in a confluent way. And I think one of the problems when we did the laser ablation and we had a fair amount of recurrences at 2 years is, one, the probe was $5,000. And so you could only have one probe, and when you went to ablate another region, you really didn't know exactly to get the concordance. I think that's very different with the cryo, because you can position all of your probes at one time and I think pretty reliably get the concordance. I worry a little bit more with a HIFU because any one of those pulses of energy, if they misfire, you could leave disease. So did I convince you, David?
Is mic on? Okay. Yeah, Herb, you and I are actually closer than it sounds. That I believe in targeted focal therapy, not focal therapy. And, you know, we've got a target to go after when we do the mapping biopsies. I'm glad that you said that I think you said that it is more accurate. I don't think there's any question than MRI. But, you know, MRI, you're really great at MRIs at your institution, and that's not the case everywhere. So there's going to be a higher miss rate. And that's it. And so our whole idea about the mapping biopsies is to make it turnkey and easier. And there's no question it's more invasive. But you know what? You're doing a lot of MRIs on people. We're not doing follow-up. We're following people with genomics and PSAs and things like that. We're not doing more biopsies and so forth. And we've got people out 10 years now. So there's no question that MRI is easier, that this is time-consuming, but I think it's going to get better.
No, I agree. And David and I, as he says, we agree more than we disagree. I think we're at a point that it is reasonable. Have we perfected this? Absolutely not. But hopefully technology will invest resources to really take us to the next step.